Many new med students get fever questions wrong, not because they don't know infections, but because they don't structure their thinking early. They hear fever and immediately jump to labs, CBC, blood cultures, imaging. But that's not how experienced clinicians think. Instead, they use a simple, organized framework. First, rule out anything serious, then use time course, and finally, look for key diagnostic patterns. If you can follow this, fever goes from a hot mess to something you can calmly and coolly narrow down. In this video, I'll walk through a case of fever and show you how this framework makes your process so much easier. And later on, I'll show you the key diagnostic fork that dramatically reduces your differential list. Here's our ScrubNotes Chief Complaint framework. First, we generate a broad differential list. Second, we use focused history questions. Third, we have informed strategic physical exams that are targeted. Fourth, we update our DDX to have a working diagnosis and some top differentials. And last, we create an assessment to present our findings. So let's see how we can apply this to our case of a 24-year-old male who presents with a fever. So step one is we want to generate a broad differential list. Fever has quite a huge list, but most cases fall into a few big categories. Infection is one of the most common, viral, bacterial, or other. But we also want to think about autoimmune disease, malignancy, medications, and a few other systemic causes. At this stage, we're not trying to be right, we're just trying to be complete. And next, we'll see how some key focused history questions help us narrow down this list significantly. So focused history questions is where our diagnosis can actually start to narrow significantly. First, we want to clarify about what we mean by fever. Was it something measured, a true fever, or more subjective? How high was that will give us information about the severity of the fever, and if there's any associated symptoms that can help with localization. Next, we want to inquire about how long has the fever been going on? Is it acute? That's more likely an infection. 1 to 2 weeks, that's leaning towards inflammatory. 2 to 3 weeks, more concerning about a malignancy. And if it's progressive versus intermittent, that's a key pattern clue. Speaking of pattern clues, here's some that are helpful. Cough could be indicative of a pulmonary issue. Dysuria focuses us towards urinary. Rash could be a dermatologic problem. Chills or rigors, that's more indicative of bacteremia. And night sweats could be associated with TB. Then we want to ask about any recent exposures, like to any sick contacts, because that's probably infectious. Any recent travel would be exposure to endemic illnesses. Maybe there's an occupational or environmental exposure. And lastly, we always want to ask about medications because there could be a drug-induced fever. And then don't forget to ask your red flags. Here's some concerning symptoms to check. If there's severe dyspnea or chest pain, that's concerning for sepsis. An altered mental status is indicative that there's something happening in the CNS. If there's syncope, we're concerned about shock. Someone's immune compromised, could be an opportunistic infection. And if it's a persistent high fever, that's pretty severe, so we want to escalate that. I've created this algorithm to help us approach fever, and hopefully it'll help it feel less overwhelming. First of all, we always want to rule out any red flags. So we want to check for hemodynamic stability, if there's an altered mental status, severe dyspnea, immune compromise, persistent high fever, any recent surgeries or infection risks. If any of those are true, we're sending them on for an ED evaluation. So if not, then we're going to use time as a key step here. Remember earlier when I mentioned there's a key diagnostic fork? Well, this is it. So if this is more of an acute fever, we can use localizing symptoms to help narrow our differential. So we could inquire about a URI because that could be indicative of a viral cause. Maybe there's sore throat. You might be thinking about strep or Epstein-Barr virus. If there's any dysuria present, that would be indicative of a UTI. If there's cough, that could be a pneumonia. And if none of these are true, then we want to ask about early viral exposure, drug fevers, or maybe even an occult infection. So if it's not acute, and it's more than 2 weeks, then we're going down the more chronic branch here. We're going to use systemic clues to help narrow our differential list. So we could ask about what medications they're taking. That would be indicative of a drug fever. If they've had any recent travel or exposures, there could be an endemic infection going on. If there's a joint pain or rash, that's more indicative of maybe an autoimmune process happening. And then if there's unintentional weight loss or night sweats, that's more indicative of a malignancy. So your clinical pearl from this algorithm is that acute fever is infection until proven otherwise. At this point, I think we're ready to present our case. So we have a 24-year-old male who presents with a 3-day history of fever, sore throat, and generalized fatigue. He reports subjective fevers at home and associated chills and decreased energy. He denies shortness of breath, chest pain, or focal neurological symptoms. He's had no recent travel, no known sick contacts, and no history of chronic medical conditions. Also, he's not taking any medication and denies recent antibiotic use. Now that we've asked focus history questions, our exams can be targeted and not random, which is really important in an OSCE exam. And in an OSCE setting, don't forget to take vitals and make any general observations. For our case today, I've created a little table of our top differentials, so let's take a look at how that might apply. If we suspected a viral URI, we'd want to check vitals, probably do a heart and lung exam, and also look at throat, eye, nose, ears, depending on symptoms. So for our patient, let's assume we had mild erythema but no exudates. Next, if there was a strep pharyngitis, we'd want to check for vitals again, heart and lung. Important to look at the tonsils and in the mouth. And I'd also want to palpate the cervical lymph nodes. For our patient, let's assume that there's no exudates, maybe some mild lymphadenopathy. If we suspected an EBV or monoinfection, vitals would be important for us to gather, heart and lung exam, cervical lymph nodes, and maybe even abdominal to assess for any kind of splenomegaly. For our patient today, let's assume there was no splenomegaly, maybe some mild cervical LAD. Then if we had pneumonia, again, heart exam, vitals, lung exam would be important as well, and maybe some megaphony. For our patient, let's assume we heard clear breath sounds bilaterally. And then if there was malignancy, we'd want to check vitals, heart and lung, probably full body lymph nodes. And then for our patient today, let's assume no generalized lymphadenopathy. Okay, we're at step 4 now in our framework. We want to refine our differential list. So again, we're refining it. We're probably not adding any more diagnoses, but we're prioritizing based on our focus history and our targeted physical exams. So for our patient today, I'm leaning towards a viral upper respiratory infection for my working diagnosis. I'm still going to keep in mind maybe like a strep bacterial infection or EBV as another cause of his viral symptoms. So putting it all together, we're on step 5 and we can present our assessment. We have a 24-year-old male who presents with a 3-day history of fever, sore throat and fatigue with associated chills and decreased energy. He denies red flag symptoms including dyspnea, chest pain, neurologic deficits, or hemodynamic instability. His symptoms are acute in onset and associated with upper respiratory complaints, with no significant past medical history or risk factors for immune compromise. The acute time course and presence of localizing symptoms are most consistent with a viral upper respiratory infection. Alternative causes include bacterial infection, autoimmune disease, and malignancy. All of these are less likely given the short duration, lack of systemic red flags, and absence of supporting clinical features. Before we wrap up, here are 3 common traps students make and ways to avoid them. Number 1 is jumping to labs too early. Start with the time course and pattern, and then let labs confirm your working diagnosis. Don't replace reasoning. Number 2, ignoring time course. Be sure to ask how long has the fever been going on, because that can give you key insights into the cause. If it's acute, infection, chronic, might be more malignancy or autoimmune. And third, missing exposures. Be sure you check early about travel, any sick contacts, or medications, because this often helps you get the diagnosis quickly. If you take one thing away from this video, I hope that it's fever isn't about memorizing a long list. It's about checking for any red flags and then asking focus history questions, such as how long has this been going on and what pattern does it fit? So if you use that, and fever in most cases becomes much easier to solve. So in our case today, the time course questions revealed that the patient had an acute fever and localizing symptoms that were indicative of an upper respiratory infection. We can use key diagnostic forks like time, and then also localizing symptoms such as cough, dysuria, sore throat, asking about exposure history like travel, sick contacts, or medications, and then using system clues such as unintentional weight loss, rash, or joint pain. If you want to get faster at clinical reasoning, not just for fever, but for any chief complaint, I break down how to apply the ScrubNotes framework across the entire Chief Complaint Series, linked here. So if this clicked for you, check out the rest of the videos.